Dear Chairman, ladies and gentlemen, I would like to thank the organizing committee for giving me the chance to present our case at the CVI 2019. So, 60-year-old man was admitted with a diagnosis of non-STEMI. The culprit vessel was considered to be the SVG at the point of anastomosis to the PDA. The patient had multiple cardiovascular risk factors, and although the lesion of the native vessel was a CTO, as we will see in the following slides, there were no easy options for SVG PCI, and this is why we decided to proceed with ad hoc native vessel CTO PCI. RCA CTO was of a high complexity. Proximal cap had a blunt stump. Lesion length was approximately 90 millimeters. The distal vessel was severely diseased. And we had multiple options for collateral crossing, such as SVG, contralateral, and ipsilateral collaterals. The original plan was to perform a retrograde attempt via SVG, and as a second option, in case of failure, proceed with the antegrade wire escalation. We gained bifemoral access, and we were able to wire both the distal RCA and the PDA. As we already mentioned, the PDA had a tight lesion at the point of the SVG anastomosis. So we decided to perform a reverse cart, and this is why we advanced retrogradely and knuckled gladius mongo all the way subintimally to the proximal RCA. However, initially we didn't manage to pass pilot 200 through the antegrade guide, and this is why we decided to place a guide liner, 6 French guide liner, which enabled us to finally cross through the antegrade guide. Then we were able to externalize an R350 and perform multiple pre-dilations to the RCA. However, we noticed that both the PLV and the PDA were severely diseased vessels, and this is why at this point we decided to advance a dual lumen microcatheter and wire both the PLV and the PDA in order to perform DK crash. So we initially deployed a 2.5 millimeter DES to the PLV, which was then crushed by the deployment of a 2.5 millimeter DES to the PDA. Afterwards, we implanted in total 3 drug-eluting stents to the RCA, followed by multiple post-dilations all the way from the proximal RCA to the distal RCA. Then we decided and we managed finally to pass through the guide liner 1 final drug-eluting stent and implant it in the PDA. However, at the end of the procedure, we noticed that the PDA wasn't filled by the contrast injection through the RCA, and we thought that this was caused by the competitive flow from the SVG. Because of the risk for native vessel occlusion, we decided to coil the SVG by using an amplatzer vascular occluder. And we can see that after the deployment of the coil, no flow through the SVG was evident anymore. From this video, we can appreciate the final result and the restoration of TIMI3 flow to the RCA. So our take-home message is finally native vessel PCI should in general be preferred over SVG PCI when it's feasible, since it has been associated with better short and long-term outcomes. Guide catheter extension can facilitate the performance of reverse cart, as well as the advancement of stents at the distal parts of the vessels. DK crash can be effectively performed through an externalized guide wire. And finally, according to expert opinion, SVGs who cause competitive flow and put under threat the patency of the native vessels should be coiled. Thank you for your attention.
That was a fantastic case, Iosif. I think, you know, it's certainly one of the things that I think, I don't know if you guys did this or not, do you before you occlude the SVG in these cases, you said there was no flow detected through the native. Would you put up a balloon in the SVG and then re-image the native just to make sure before you sacrifice this vein graft?
No, to be honest, we didn't did what you...
You weren't worried about it?
Yeah, I mean, I think that it was like pretty obvious as you saw the picture that there was no flow at all. Like TIMI flow was like a zero at the distal PDA. I mean, to be honest, I wasn't familiar with the technique that you described.
Yeah, no, I think...
like a really good recommendation.
Yeah, it just may, I just thought of it just because it's more than likely the cause of why you don't have flow in your native, but just in case there's something else going on, you just want to make sure, maybe you have an osteal dissection, guide-induced dissection, something like that, and then here you are sacrificing the vein graft. So it's probably an unnecessary step in most cases when you're coiling. I don't know, Jason, what do you think?
Yeah, I think in this case, they got a nice shot down the vein graft, and you could see that there didn't appear to be any trauma to the PDA that was going to need to be addressed. So I think at that point it's probably fairly safe just to jump in and get the coil. The other thing is if, God forbid, he did have a dissection, you've got access and you've got a wire across it, so I think it'd be pretty safe at that point. I'm curious the decision on when to use a vascular plug or when to use a coil in this situation.
Yeah, actually, there are no robust data on this. You're based mostly on the opinion of experts, and to be honest, I'm not really familiar with this. So it depends also on what equipment do you have.
Yeah, I think either can be used in this situation. This is a graft that didn't actually have a tremendous amount of disease in it, and so I think a vascular plug is very reasonable because it's going to be fairly easy to get a guide down into the graft. But if, the majority of the time, I think people are using coils just because it's a lot easier to get there. You can get a microcatheter down a vein graft a lot easier than you can a 6 French or 5 French guide, depending on the size of your plug. But yeah, I think that was a great choice in this case.
Yeah, I think with this big graft, the coils, you'd run the risk of them embolizing down without, being able to form a good ball there. So I think vascular plug was the right choice.
Typically, if you're going to use a coil, you try to put it in an area where there's a lesion in the graft, and that can be your backstop for your coil. And then the nice thing with grafts, because you've got a long area where you can deploy these in, oftentimes using a bigger coil that will give you a little bit more radial strength or radial diameter can be helpful to minimize the risk of embolization.
Go ahead, you have a question?
Just a question. Several talk about coiling those grafts after we open in CTO, but that graft was not competing with it was probably competing with PDA. What's the harm of just leaving it without coiling?
Well, I think when you have that degree of competitive flow that the vessel downstream isn't filling essentially at all, the risk is that with that competitive flow, it's going to be a setup for thrombosis. And so having been on the wrong side of this and having to deal with stents that have then thrombosed, it can be a real hassle. And so I think, there's certainly a healthy debate when it comes to SVGs, when to coil and when not to coil. But I think that there are some of the mindset that they coil everything. There are others that coil almost never. But when you see this degree of competitive flow to the point that you're not filling the distal vessel at all from the vessel that you just put stents in, I really think it's the safest thing is to put a coil in.
Yeah, I agree.
The graft's dead. You've already given up on it. It's not giving any.
I think what pushes me towards something like that is when you see the competitive flow. I mean, if you stent and you're not seeing the washout, then you're probably less concerned. I don't think you need to coil every single vein graft that you stent the native. I don't know what you guys feel.
No, I agree with you.
Yeah.
Go ahead.
No, I mean, I think that degree of flow where you don't even have flow in the proximal vessel, all the work you've done, you've got to coil it or close it somehow.
I thought leaving the externalized wire in was an interesting choice too. I think I personally probably would have gone and switched to a fully antegrade system. The key though is if you are going to use your externalized wire for a bifurcation, you need to make sure that the externalized wire will never be in a situation where a stent can get crushed on it. And so that's why you had to put your initial stent into the posterolateral branch, always remembering to have a balloon distally to crush, because you just never want to trap an externalized wire. That was an excellent case.
Yeah, that was a great presentation for a teaching standpoint, so well, nicely done.